Don is our speaker tonight. There's probably not too much that that Don hasn't done when it comes to volunteering with various cancer groups. He's currently co-chair of the Cancer Strategic Clinical Network in Alberta, and also the Cancer Diagnosis Initiative. And he's been doing this for 5 years now. And he's also part of the Patient and Family Advisory Council for the Cancer Centre here at the Tom Baker. And he's got probably more information about cancer generally than most, particularly in terms of his volunteering. So Don, if that's okay, I'd like to turn the meeting over to you for your presentation.
Oh, thank you, David, and welcome everyone. Yeah, just while this boots up here and gets ready, a couple quick things. I was making notes, David, as you were saying there. So I loved your, I wrote it down. It's time to talk openly about prostate cancer. I love that because you'll see when I present tonight, I'm pretty low key and open, and I like the two-way engagement as much as we can. So the more the better. So if people are savvy with Zoom, if you have questions along, don't hesitate to stop me. Put it in the chat, and somebody can poke me when there's a question. Put up your hand, whatever you like, because I like this to be a two-way conversation. That's why we're here tonight. I'm here to give my kind of experience and what I've been through, and maybe some things that I've been doing, and then vice versa. I always find that I learn more from the people in the group, and the two-way exchange is always the best thing for me. So speaking of the new Cancer Centre, I proudly wear my own shirt. This is the campaign that they're doing to raise money. I bought everybody in our PFAC group at the hospital one, so we wear them once a month in our meeting, kind of to remind us and to ground us. Plus, it's been a good fundraiser. From a personal standpoint, my involvement with and experience on prostate cancer and prostate issues is somewhat limited, other than my grandfather and my father both had prostate issues. So fingers crossed, so far my father's been fine. I was actually at a specialist appointment with him today for something else. He's turning 80 on Friday. So I was his scribe, because as he gets 80, he's not as savvy on taking notes and stuff as us younger people are, as he calls it. So and with that, just really easy. We're going to do a few slides tonight, take a bit of a break, watch a video that I was involved in about a month and a half ago, and then we can talk about what's going on inside that building and what it's going to be and what it's going to mean to all of us. And then I got some slides that we'll go back to that just kind of ground things for me and what I'm going through and where I'm at now. And what I'm doing and what my family's doing. So hopefully that resonates with everybody, and we can have some kicks and some good discussion about it. And I'm really good with time, so you'll see that I've started my clock. So I'll keep an eye on that, so you won't have to poke me. I always call these my ground rules. Like I said, I'm completely open and engaging. Don't hesitate to ask me anything. I always tell, especially when I'm giving talks to nurses and stuff, you're not going to make me cry. You're not going to upset me. It's all good. We all have learned experiences. So I think it's really good that we have those two-way conversations. Like I say, I call it unfiltered therapy. It's just kind of my way of making sure that we're sharing and we're getting as much out of this as we can. And like I said, I love your theme line. It's time to talk openly about prostate cancer. That's awesome. So we can have that forum tonight. And really my summary, my passion since my wife passed in 2020 has been oncology research and giving back. She was also actually a volunteer and heavily involved on the research side. She was really interested in immunotherapy and the new things were coming out. So, sadly it was cut short for her, but I've continued that on, and I think, somewhat continued on her passion. So again, just, kind of more what we just talked about. I'm here to answer your questions. It's absolutely a two-way discussion. I always tell when I meet with, clinical teams and stuff, engage your patients, families, and caregivers on day one. So I'm a big fan of loose talk with our oncology team and our specialists and nurses. I call everybody by their first name. I make it peer-to-peer. I try and make it friendly because, those people are in difficult situations, especially, not only because of the stress of the environment, just what they do, but with the last 2 years, what we're going through with COVID, it's put, that much more pressure on the system and on people. So I'm very respectful of that. My daughter is actually a nurse on Vancouver Island. So she's in the profession as well. I think, what we went through as a family, I think, has really driven that to her as well. So she just started her career in nursing this year. So I'm super proud of her for what she's doing. Couple of quick things. Somebody gave me a poke. David asked at the beginning how long I've been, volunteering and stuff. And yeah, it's been 5 years. It's gone by kind of in the blink of an eye, only because of circumstance and what we've been through and where we started. But I'll talk about that in a little bit. My kind of summary statement I tell everybody is, when you're dealing with the healthcare system in Alberta, and I'll speak specifically Alberta, even though I was raised in BC, is, window gaze at the system. I kind of have a different perspective now because I've been, on the caregiver side for my wife and my family. I've been on kind of the working side, and I work peer to peer at some pretty high levels now, but I treat, everybody that I work with there as a peer as well. And, I'm very open about it. We need to recognize that, yeah, the system needs work, and it's an ongoing process. There's a definite elephant in the room, I think, as we all know, but there's really good people doing great work and trying their very best. So I try and do my little bit to add some, what I call outside expertise, and maybe some business expertise from what I went through as a caregiver, plus having experience in the business world that maybe on the healthcare side that people don't necessarily have. So I always say, if we always did what we always did, we're only ever mediocre. So it's all about pushing the needle and trying to make things better. And that's why I do what I do. I was trying to kind of summarize some of the things that I've been involved in. David did a good job of making it easy at the beginning, so I won't bore everybody with this, other than I was sitting in treatment in systemic therapy. Sherry was about to go in for chemo, and I was looking around at things. I think she'd been through 3 or 4 rounds of chemo, and I was recognizing things that I thought in the system, like, maybe there's a better way to do that. Maybe I could give some advice on what our experience has been that maybe one of the professionals wasn't picking up on, or maybe there was a miss. Or, when you're sitting there in treatment room, you're talking to other people that are getting treatment. You're talking to other caregivers. You're having a coffee in the hallway. You're bumping into the porter. The porter was always my best friend in the hospital. You get to know those guys, and they have the most incredible stories. And I was kind of moved and thought to myself, I wonder if there's a way to get involved and give back, because I think there's real value there. And there's a plaque at the baker downstairs, right behind the pharmacy, that is actually from the Patient and Family Advisory Group, kind of what they do. And I just happened to look at it, and there was a little open folder thing, that you fill out and you send in. So I said to Sherry, I want to fill this out and I want to send it in. I want to find a way to give back. I didn't know what that was going to be, whether it was, I'm going to be one of the guys that's handing out coffee or something, but I wanted to be involved kind of from my experience as a caregiver and what I was seeing. So that's really where things started from. It's a long story, but I started getting involved and asked to be in more and more patient and working groups. I tried to limit it to things that I thought I could add some value in. So I didn't step into things where I was kind of an outsider. I wanted to have, I call it that lived experience, and share that. So I've tried to kind of stick my volunteer career to that. What happens, and any of you that are doing it now, is you tend to get tapped on the shoulder a lot more. And this was when COVID's going on, all these other, or before COVID was going on, we were able to meet in person and doing some things. So that was great. So you build a bigger and bigger network of value, and people can pick you out of that and say, hey, are you interested in this? Because I think you could add some real value. So it kind of expanded to that. I was always interested in clinical trials and the clinical trial side. It didn't work for Sherry. Her tumors were such that there wasn't a clinical trial available, but we certainly, and I'll talk about it in a bit, we certainly tried to use and get educated on every part of the system that we could, so that my job as a caregiver was, I always said I was the business side of things. She was very, I called it Zen-like. She was very much, her job was to get better and focus on feeling well and her treatment. My job was to read all the doctor's notes, read all the medications, find out what did what symptoms she was going to have, what was going to happen, and kind of be, I called it Dr. Don from an armchair. And, I tried to avoid the Dr. Google at that time, as they tell you when you first go in for, when you're first diagnosed. But I took it as a, almost like a full-time business role. And I tried to stay as unemotional to it as I could, from the respect that my job was to have that, have her back on that other side that she didn't want to get involved in. So this is where it's kind of grown to now. So I've been heavily involved, especially at the Baker in the Foothills, with the Patient Family Advisory Council. I'm now on, I think I'm year 3 or year 4. And then last year in 2021, I joined the Patient Family Advisory Group for the University of Calgary for the Cuthbert Lab and oncology outcomes, only because I knew a couple of the doctors and the good work that they were doing, and I thought I could add some value. Sherry had stage 4 metastatic colorectal cancer, and they've done a lot of work in that area. So I thought I could add some value there. So there's been some kind of other spin-off volunteer things. And once you start to understand and you get more embedded in the system, you see that these kinds of things come up. And then for now, kind of the biggest thing that I do that takes the most amount of time is we've started a new initiative called the ACDI, Alberta Cancer Diagnosis Initiative. So I co-chair with Barb O'Neill, who's the provincial director, the engagement and design portion. So what we're doing is trying to, for all Albertans, build a program together with Albertans to educate about cancer, bring in all groups, whether it's subpopulations, newcomers, First Nations, young adolescents, all aspects of us as Albertans, and get their feedback through primary care and together with primary care on what's a better way for everybody to get into the doctor, to get diagnosed, whether it's walking to the ER, seeing a primary care doctor, having a specialist referral. How do we better and faster get people diagnosed and treated? So it's really revolutionary what we're doing, and it's new. It's being keenly watched in other parts of the world right now for what we're doing, because we're trying to move the needle. And I talked about kind of that elephant in the room. We're trying not to fall into the stigma of the healthcare system and the behemoth that it is. We're trying to step back and step out of it. And we've brought on a third-party consultant that specializes in this, a design consultant. And what they do is they set up the interactions with people for interviews and stuff out in the community. So we're really engaging everyone, engaging Albertans overall as to how we pull this together. So really exciting work, but it's a big time commitment. So, here's my humble thing. So it was nice in 2020. I worked in the environmental business as a consultant. I stepped back shortly after about 8 months into when Sherry got sick, and I made a humble statement to myself that I was going to be there for every appointment, for every treatment, for whatever happened. When you got a full-time career that was 100 hours a week, 24 hours a day, 7 days a week, it just was in a situation where it wasn't going to work. So I stepped back, went to work for myself, which basically was nothing, a little bit to keep busy so that I could focus on her care and look after her, because we didn't know how much time we had, but I knew it was serious, and I needed to do what I needed to do for my family. So I was recognized in 2020 by our industry as an exceptional volunteer from actually a friend of mine who passed away, Jerry Barassa, actually from cancer some years. So the industry on a whole gives an award once a year. So in 2020 at their annual meeting in Red Deer, I was honored to be the recipient. So it was nice to, kind of be honored when you'd stepped away and stuff for what you've done, in that you were going to do something different and, be involved in something different, and people had some respect for that. So I'm very proud of that. So this was a video that we got asked to do from the PFAT group. They asked for a volunteer if somebody was okay talking in front of a camera and stuff. And obviously I've done enough of it now. I do quite a bit of guest speaking, so I'm not nervous usually doing this kind of stuff. So they published a video which is playing now. If anybody's sadly having to go into the hospital right now, they're playing on the TV screens and stuff as kind of an education right now for the new cancer center before it opens up, about what patients and families have been involved in and how we're involved in a little bit of what we do as a patient and family group. So you can just go ahead and play it, Rhett. It's 3.5 minutes long, so it's quite short.
Alberta Health Services. Healthy Albertans, healthy communities, together.
She passed in April 2020, so that's been another key kind of motivation for me to stay involved and do more things, and for my family. It's truly been developed with patients and families in mind, and everything you look at, that's how it's been built. So it's a friendly, open atmosphere from the time you walk through the front door.
They've played integral members of our working groups. So not only do we have the clinical experts, the FM&E experts, but we have patients and families at the table talking about the patient journey, helping us with patient flow, telling us what parts of the system they found challenging, and pushing us to think creatively of what could we do differently to make it better for patients and families in the future.
When we were able to hear their stories, we were able to really learn to empathize and to learn to put ourselves in their footsteps. And their experiences that were shared with us became very, very real to us.
For me, everything we do is in memory of our daughters. So it feels a bit surreal that this is all happening, that this is all coming to fruition. We've worked really hard and we've advocated really hard for these experiences. And our hope is always just that in talking about it and in coming forward and in sharing what we went through, that someone would hear us and someone would make it better for the next child. And I just feel really honored that we get to be a piece of that, of creating a better legacy and a better experience for these families.
The PFAC will be with us in some shape or form for many, many years to come. How do we embrace new technology? That'll be a PFAC help, right? How do we make adjustments in terms of patient flow for those things that aren't quite optimized? That will be fed back to them. It'll be a journey that we will go on for the life of the building, I suspect.
Together, we do amazing things every day.
Yeah, so I think they did a good job in just kind of giving everybody kind of a briefing and stuff and letting them know a little bit about what we do. Does anybody have any questions or feedback on that before we go on? Just anything that you saw, or I know it goes by pretty fast and you're trying to look at everything, but I've been fortunate enough, I've been through the building 3 times now. I went through on the first time when they literally were pouring the foundation. So there was very little there. The second time, I think it was 3 floors that were up, but it was purely just concrete and 2x4s up. So we were limited in where we could go, but you could kind of get a feel for what it was going to look like, which was pretty cool. And then obviously when we did the video, I was able to truly see what the facility, in its almost finished state looks like. I'm not an engineer, so somebody will get me wrong if they're an engineer, but I think it's in like a level 4 status right now, which is why you saw us in PPE. So everything is taped and all hermetically sealed and everything so that it stays, perfectly clean and pristine and stuff while they get it set up. So it's very, very cool. And it's a real honor to be able to go in there, before it opens next year. So for me, it's the ultimate prize for what I've done as a give back. To be able to have that and be able to have that memory moving forward. So I'm super proud of what we've done with our group. And, like they said, we've been involved in, how the parking lot it lays out, especially for people that are going into treatment. Wayfinding is a huge thing. From the time I walk in the door, where do I go? Do I turn left? Do I turn right? As we all know, especially, no disrespect to the Foothills and the Baker, is I always use the analogy, you walk into Foothills, you turn right and you're at the Foothills, and nobody talks to you. Everybody's got their head down because people are being treated for, they're in there for an operation, a heart procedure, a broken arm or something. You get in the elevator and everybody kind of stares at their shoes or drinks their coffee. You turn left and you go into the Baker. And I always say, as soon as you cross that threshold, people have their heads up, they're looking at you, they're saying hello, you're walking in, because we're all there facing cancer. And that theme is moving over very much so to the new cancer center. especially with, all the research and everybody from the university are going to be there. Everybody is finally going to be housed in a togetherness in a proper hospital that's just there for cancer. So I think it's a huge win, for patients and families overall. So super proud of what they've done. Like I said, it's truly an amazing facility from the way it looks on the outside to once you get into the inside.
Don, if I could ask you a question?
Yeah.
Thanks for your presentation. It's great. The new facility, what is the difference between that one and the newer one they built at Rockyview? Like that was a fairly new cancer center as well. Yeah, at the Rockyview there, they have that. They just built one up there a few years ago.
At the South Care campus?
No, it's at the Rockyview. It was the one.
Oncology. Cancer Center.
Yeah, the oncology center there.
Oh, okay.
Yeah. What's the difference between the two of the buildings?
Yeah, I didn't have any experience other than my son was born at the Rockyview. All our care has been at the Baker and at the Holy Cross. So I wouldn't be able to help you on that one. My assumption is because it's fragmented and things are all over the place, with everything being housed at the new cancer center, especially with the new technology that they're putting in, a lot of the new technology they're putting in, including the LINAC vaults, which don't ask me if I'm an expert on, I'm certainly not. I had to Google it, and we had a very cool presentation given to us by a radiologist on exactly how that's going to work. But that's game-changing worldwide technology. And I think we're only going to be the second cancer center in Canada with that technology next year. You can have surgery done like robotically or however that's done, all in like 3D. They were showing us like a live simulation on it, and you can actually see everything within your body and where the radiation is targeting, as opposed to, with traditional CT and stuff. So it is absolutely amazing technology.
John, the acronym PFAC was mentioned a couple of times, and I know Alberta Health Services is big on acronyms. It's Patient and Family Advisory Council. And
Correct.
If you want to just talk a bit about that, just so people know.
Yeah. So there's many patient and family advisory councils in the province. So if you go like on the website, there's actually PFAC sites where you can look at all the different PFAC sites on who's involved where. So what it is right now, I think we're 16. We're trying to get up to 21. We want to bring some new people into the committee. Sadly, we've had a couple of people pass the last couple of years, which is a reality of what we're all facing. And that's why we become very, very close in our group. So it's people from all walks of life who face cancer. I'm there as a caregiver. We have a lot of patients there. We actually have a couple there. So he's a patient and she's a caregiver who I've got to know very, very well. We have physician representatives. We have Don Morris, who you saw just get interviewed there, and Carolyn Thatcher. They're there in our meetings every month. Don always says to us, he's got a hospital to build and he's in charge of the hospital and he's medical lead. He wears a ton of hats. And he always says it's his favorite meeting of the month to come to, because we have an ability to openly talk about what we're going through, what we think should be added, or where things should be, what works, what hasn't worked. And they're able to take it back as professionals and clinicians and take that back to their groups. It's an equal vote and an equal discussion. Kind of the going back 3 years ago with PCL, who's the contracting company building it, our feedback was crucial, and on the tick list on everything that they're building and everything that developed, it's on there. Was PFAC consulted? Were there working groups consulted regarding the art, regarding this? I'll give you an example. I was on an art review committee, and I'm not an art person, but I'm like, okay, well, that's interesting. But so they were showing us pictures and, wayfinding pictures and what they meant. And one of the pictures came up and it put me off. And the young lady said to me, Don, what's with that photo that is bothering you? And I said, well, to me, it was very abstract. To me, it looked like a tumor. It looked like what I'd seen from one of our oncologists. And it was a picture that they were going to hang in radiation. And I said, well, if I was going through radiation and I was, let's say, laying on my back and I'm staring at this thing while I'm having my cancer treatment, that's an off-putting moment. So the consultant took it into consideration. She's like, we had no idea. We never thought that. So those are some of the things that we're trying to bring, that kind of lived experience, and I call it across the table expertise, that maybe isn't there, and maybe when you're truly involved in the system and you're doing what you do, you don't necessarily see. So it's really just a group of people that have come together to try and give our expertise and be embedded wherever we can. So that's kind of the simplest way I could sum it up.
Thanks, Don.
Oh, you're welcome. So I'll kind of go on to this. So, being a caregiver, for those who, been through it, patient has a patient's a patient. I don't know what it's like to be a patient. Thankfully, I've had good health, but I know what it's like to sit across from a patient and somebody that you care about. Being a caregiver, unselfishly, is an incredibly hard job. For anybody that's been through that role, whether it's, a wife, a spouse, a friend, a family member, it's a very, very difficult role. I'll just say that. So I'm very much a fan of anybody that does sadly have to become a caregiver and is that role. I'm super proud of you, and what you do is really, really important. There's no stigma attached to anything, and I just think it's super important. And a big reason I do what I do is to give that caregiver perspective, because a lot of professionals, a lot of what you see in the profession is patient, patient, patient. I'm like, what about their families? What about the people that are looking after them? What about their kids? What about psychosocial issues? What about financial issues? There's all kinds of other things that go on when you walk out that door that you need somebody there to hold your hand or call or play that role. So I'm very proud of it. And for those people that do it, I commend you. So real quick, we started at the beginning, but Sherry was diagnosed in 2017, went through 3 major surgeries, 29 rounds of chemo, 6 rounds of antibody treatments. Outcome was basically everything they tried wasn't working. The tumors kept growing because it had metastasized. At that time, it moved into her liver. It just kind of started to get worse and worse and worse. So like I said before, she was very Zen-like, I called it. So she was very big into getting alternative therapies as well, naturopath, Reiki, massage, homeopathic remedies. She was involved in Wellspring on the psychosocial side and other sides to get, kind of that mental grounding that she needed, as well as talking to other groups to get support. So we did everything we could, I think, as a group in a 3-year period. It went by like it was about a month and a half, because you're walking around in a fog and you don't really know what's going on. It was like being in a bad dream all the time, the emotional roller coasters that you go through. So it was really tough. So I always put up this slide. It just kind of reminds me of what we went through and some of the things that we did. But, ultimately, I'm a big fan of quality of life. And what is your quality of life? For those of you that have gone through your surgeries and changes, you know what quality of life changes have had to come and you've had to adapt to, and your caregivers have had to adapt to. So those are big things that I talk about a lot, and things that we should never take for granted. So I think it's really important that we keep that front and center. Believe it or not, just after Sherry got sick, she had a work friend who came over with her 2 little young kids, and we never saw her again after that, because when Sherry broke the news to her that she had cancer, she never came back because she thought it was contagious. So I talk about stigmas and ignorance and stuff. There's still a lot of ignorance in this world that goes on. So I'll never forget that, which is a reason to advocate and a reason to educate people. So I kind of have a rule here on things to do, especially if you're newly diagnosed or your caregiver spouse is looking at, what can they do to help and what do they do? So week 1, I say, call Wellspring. They do incredible work. They have all kinds of programs that can help, and I'm a huge fan of what they do. Your group, from what I've read and what I've seen, and everything Dorothy's been dear to me all these years, and I owe her a great deal, is join the society, get involved. Just like John said at the beginning, I'm a big fan of, if you can get on the board of directors and give back your experience. Giving back as a volunteer and giving back your time is the most important thing you can do. And then to your oncology team and whatever groups you're going through now, past groups, or if people are just having check-ins, I call it your clinical group. Make your oncology team your team. Sherry had badges done up for them all, and they wore their badges so they remembered her. Find a nurse delegate. I was a big fan of kind of breaking the system a little bit. When I found things that I didn't think necessarily were being done right, I sought out the person who I thought could make it better. And that was for me a nurse designate. We become dear friends and we keep in contact now. So there's key people within the system that you need to learn to navigate. And really for me as a caregiver, that was my role, to seek out those people and seek out those roles to get the best care we could, and to get those things that if there was a gap we felt we were missing, we would go to her and try and use her as a navigator. And then engage, right away. I'm a big fan of, I call it supportive care. Palliative care is still the, and the palliative team is still the verbiage that they use now, but I think those are some of the most special people in the entire healthcare system. When we were finished treatment and Sherry was at home and we were having home care, there were some of the most special people I've ever met in my life. So I can't say enough about those, I call them angels without wings, what they do, because they helped me and helped her a great deal. And even up till the end, I'll never forget it. And I've taken it always. This has been a positive experience. It's no fun to go through. I don't wish it on anybody. But when you're dealt with properly, respectfully, and empathetically, it makes a great deal, and it made it a lot better for me and my family. So, kind of why am I here today? I think we've kind of already talked about that. Quick slide here. When I was cleaning up our things, I found this letter on the right that Sherry had in an envelope just stuffed in one of our drawers, and I was going through everything and cleaning it out. And these were 3 goals that she'd written down for herself. Sadly, number 1 didn't happen. Number 2, we were able to do. She told her surgeon after she had a surgery called HIPEC. Please don't ask me to enunciate it because I can't, but basically it's heated intravenous chemotherapy put through your body in an 11-hour operation. It's one of the biggest operations that they do at the hospital. And they basically recirculate your entire body and all your organs with chemotherapy. So it prolonged her life, and it really helped. So I remember saying to her surgeon, she's like, just get me healthy enough so that I can go on a holiday. And that was able to happen. And she wanted to write a book and get it published. And I know a lot of people say it. I've got a lot of stuff on my desk that I've been writing down and keeping. I still plan on one day, I think, writing a book about what it's like to be a caregiver and our experience and sharing that, because I think it's super important to give back. So I call it family time now. I presented a few of these slides to our PFAC group. This is another thing we do kind of to help each other, is we take turns having a 10 or 15 minute, we'll give a 10 or 15 minute talk once a month. I'm actually up in March now to give a talk. So they've known me from when she was sick to, to what we went through, to when I lost her, to where I'm at now with my family. So last year when I presented, it was shortly after she'd passed. My kids live on Vancouver Island. We went to Vancouver Island to spend some time with them and have some healing time for my son here. So this year I'm going to present, now it's a full year, or 2 full years past. Now, how are we feeling? What are we doing? How am I giving back? So I'm going to talk about now some of the things I'm doing on the volunteer side. Most people in the group know, in our group, know what I'm doing, or even been involved in some of the things that we're doing. So I'm going to share that in a bigger way. And then what we do afterwards in every meeting is everybody takes a Post-it note, and we put Post-it notes on what resonated in the talk. What would you like to hear more of? What's working? What helps us therapy? I keep them all, and I keep them in my book. And what I'm going to do this year when I present is I'm going to scan them all and put them on a slide and go through them, because it's been 2 years since people wrote stuff to me, and I want to reflect on it, and I want to have them reflect on it. And I think it's really good therapy for us giving back to each other. So those are, some of the things that we do in our group. So for me now, I basically took 1.5 years off work. It was family time. I spent a lot of time on the island when we could still go there, when COVID wasn't so bad. We have friends. It's always nice to have friends who have boats. Looks like mine, it's not. I wish it was. We spend a lot of time at the lake. We try and do as much family things as we can to, especially for my son. The first year for him was really, really difficult. He was 12. He flipped the switch after the first year, kind of her first year anniversary of her passing. He flipped the switch. If you have kids and you've lost people to cancer, it ages them, and it ages you, or ages me. My gray hair has grown in, but he's had to grow up way too fast going through this. So it's important to keep your family really close to. So staying connected, I was telling you about the nurse navigator that we became friends with. I came to find when I was going through all Sherry's stuff that every month when she was feeling good, she sent a happy face picture to the nurse to kind of cheer the nurse up too, and make her feel good, and remind her that we were thinking about her in the professions too. and what they're going through. So we continue that tradition. I send a nice picture once a month of how we're doing, and when we're in a happy, we're having a happy day and a good day. And I think it cheers her up, and I get really good feedback from her because I'm super respectful of the profession. If nothing else resonates with anybody today from what I'm talking about, I use this all the time, and I say it all the time. I used it in business. Steal with pride. Everybody, there's experience everywhere. Never think that you're the only person going through what you're doing. You're the only person trying to learn about your therapy. You're the only person trying to read a lab report or something that, our oncologist is talking about. Find those people who've already done it, who have that experience, because I don't think anything is new. I think everything's been redone, or in some aspect, there's people out there who have expertise. Find them and steal with pride, I call it. Find out what they know and use them as your network. It's been huge for me. I use it all the time now. I use it in all my AHS meetings. I'm like, guys, why are we rehashing something? I'm sure there's somebody that's written a report somewhere that we could do a research doc on and find and use. So do that. And I'm in all sincerity here, I wrote it at the bottom, and that's my phone number. If you're stuck or you got questions, or your spouses or somebody has a question, have them call me or send me an email. Happy to talk, happy to give whatever feedback I can, because I think that's important to do. I didn't lose a spouse. I gained a family in the healthcare system. And it's important, I think, to keep that going and to keep that sharing. So kind of a couple of quick final slides. This has been fast, and thank you for today. Reflect, and include the patient and family perspective always. This is what I tell our clinical teams and those who are looking after you. Everybody needs to get out of their comfort zone, including all of you. Step back and do that. I say on the other side here, what do you do moving forward? I'm a big fan of walk the building, I used to call it. Whenever I was at the hospital, I'd go outside, I'd go through the tunnels, I'd go wherever in the hospital I'd been, and I'd think and just kind of go through things, because when you've been to the hospital as many times as I've been there, you get to know a lot of people and you get to see things. It was therapy for me. It makes me feel good. Ironically, before COVID, my son asked me all the time, we used to go to the foothills all the time and walk the tunnels, because he loved it there. He remembers, the porters that's where we used to take mom back and forth. Mom was having surgery. He knows where she had surgery. He knows what floor she was on. It's been really good therapy for him to see that. And with the new cancer center, we drive by the new cancer center all the time. I show him what's where, what's going to be where, and he's super excited about the first time we're able to go through there. So my summary statement on this one, is make a commitment to yourself and be selfish, your family and your oncology team, because you all are one big team. And even this group that you're in as a peer-to-peer group, these are special people in special groups. Share with yourselves and share openly, because don't think that you're the only person going through this. For me, I say it all the time, this is actually therapy for me. It's my form of therapy. I'm not a hugely emotional guy. This is my way to give back, and this is my way to kind of heal and do this, is to continue to give back and tell a story. And I always say it's about those who come after us. It's not about me. It's not about, that poor guy who went through that, who lost his wife. It's not about that. It's about people that come after us and giving education and experience, so that people are on a better path when sadly they have to go through this in whatever way, shape, form it is, hopefully for nothing but positive outcomes. But stay positive and be out there, and just thank you. And Dorothy, thank you. It's so nice to connect again with the lineage as we go way back. So it's funny how worlds come back.
I have a question.
Yes, sir.
You're speaking to many of us who are the patients, so to speak, and it's hard to sort of put our brains into those who are supportive of us.
Yeah.
And that's a tough one. And you've put it very nicely here. I'm quite impressed.
Like I said, I don't know how to answer the question, because I haven't been you. I haven't been the patient. I had to be the person sitting in the chair beside, and it's difficult. I can't imagine, because you're processing everything. Plus you have, if you have physical symptoms, all kinds of other stuff that you're going through. I don't have that. The only experience I could give was empathy and get trained as best I could, so that I was hearing everything and I was bringing everything in, so that I was able to help at home. I was able to help at the hospital. I was able to do different things. And that's really what the role was all about.
I have a question, Don. For example, I'm talking about palliative care. Is the hospice end of it a component of palliative care? Geez, I can't talk tonight. My brain stopped. Or is it completely different than
both. Yes and no. So different stages have different kind of connotations to it. So I'll do it backwards. So Sherry passed away at home. She was going into hospice the morning. She passed away at 11:30 at night. She was going into hospice at 7 a.m. the first morning. My take that I'm going to live with for the rest of my life that helps me sleep at night, makes me positive, is I say she checked out on her own dime. She wanted to pass at home. She did that. She didn't want to go to hospice. So hospice is an end of life space. They're incredible people do incredible things. So that's a true end of life space. So you can make a decision to go to hospice. You can make a decision to pass at home, or now there's alternatives as well. So that's kind of the backward side of it. If you went the other way, palliative care is something that can be offered to anybody at the very beginning. I've been advocating as much as I advocate, and I bang the docs and the nurses over the head all the time with this. I'm like, I was so overwhelmed when we were told her diagnosis in that meeting, when you're told you got 12 minutes. Yeah, you have stage 4 colorectal metastatic cancer. You probably have 2.5 to 3 years to live. You start treatment on Tuesday. I got to go. And literally that person left. And, my wife is crying and weeping in a state of shock. They left me a state of paperwork like this. And the first thing that was on the top of the paperwork, and I'll never forgive the professional who gave it to me, was do not resuscitate card to sign. I said, are you really going to give me that right now and expect that she's going to, in any kind of condition, to sign something like that when we haven't even had time to process this? So that's where palliative team can play a huge role, and a psychosocial role, on talking to those professionals about, hey, I don't feel good about this. Who do I talk to on the mental aspect of what's going on? What about an exercise program? What about diet? What about all those other things? So I'm a huge fan, which is why I call it supportive care. Make it at the very beginning and make it part of your care plan all the way along, and advocate for that, because it's a huge thing. Sherry was very upset at the term palliative because she thought it means I'm dying and I'm going to die. And that's been a connotation in Canada. And I've talked to lots of palliative groups about this, and many of them share the same things. And there's this whole movement to know it's an education process. We're here to help. It's very much a supportive thing. And that's exactly what they do. So kind of the answer to that is engage them at the beginning. They'll do everything and be as engaged or not engaged as you're comfortable, or your family or caregiver is comfortable with. And such is with your goals of care program. If things are going down a path where, maybe remission or cure or something isn't going to be there, where there's going to be further treatment or stuff, they can provide all kinds of options and things. And then if you get into a situation like where I was at, where you're facing an end of life situation, that's where the palliative team for us engaged home care. They got us all that support. They engage hospice if that was going to be an option. And it moved me kind of into a different space. So I was better able to clarify and understand things, because literally, we were our oncologist for the last time. He's a great guy. I love him. I hug him every time I see him. And he's like, I'm done what I can do from a medical standpoint. So that's when there's kind of it's not a pass off, but there's another path and another journey here to go to. And that's where those people get engaged.
I will tell you that palliative care is something that has been trying to get that word out there, what Dawn is just talking about. But palliative is not end of life. Palliative has to do with pain management. It has to do with mental and social and emotional supports. And it has to do with all of that real life stuff that isn't necessarily medical. So that's where incredible work. So that's where we need to get the word out there. Palliative is not end of life. End of life is something completely different.
Yep.
Thank you, Paulette, you had a question?
I guess I'm still trying to kind of get my head around this. Bob was trying to explain this on the weekend, and I and a couple of our friends were arguing with him, saying that palliative care is hospice. But no. So what I'm thinking, palliative care gives you will help you get the help at home. You're not necessarily in a hospital, in a hospice, anywhere. You can be at home, and they will help you with getting the help to treat the person, treat the patient, because I'm the caregiver like you, and they will help you with everything to do with what's going on at that time with stage 4 cancer, what you need to know, whether it's mental health, physical health, or anything else. So that's what they're there for. Do I get it right now? And whereas hospice is when you've decided home, you can't be at home maybe anymore because it's too much for you or maybe me to take care of if it ever came to that. And so now we're thinking going to the hospice is a better thing. Is that what I understand? Am I kind of getting it?
Yes.
Yeah. And Dorothy touched on some other great things like pain management and stuff. Like I totally embraced it. They're very special people. And like I said, I wish I would have been engaged with them from day one, because especially on things like pain management, like I had to change her port and take her port out and stuff. So I had to take training for that. I had to take training on how to give needles and stuff. And so they helped me with all that kind of stuff, which was a huge, huge piece of it, so that we could spend as much time as we could at home. So there's nothing worse than having to go to the hospital for a 2-minute thing that I could be trained to do. It's that whole quality of life aspect that I talked about earlier, right? So there's these different stages and paths and stuff. So from my standpoint, I'm a huge fan and advocate of engage them as early as you can as part of your overall care plan, because they can add so much help.
So where did you go? Like, did your doctor say, okay, I'll give you a phone number, or?
Yeah. So for me in Calgary at the Baker, because I took on this role of I'm going to learn everything. So I'm like, what is the psychosocial thing? What is that? Is that like if I'm not feeling well mentally, I go see those people? So our oncologist is like, no, not at all. He goes, hey, let me bring somebody in from from that team. No, we can help with pain management. And at that point, she was going through early treatment, and things like we were getting used to what diet was going to be like, and all those kinds of things that are difficult at home, especially as a caregiver. I had to be careful in what I cooked and all kinds of other stuff. The palliative nurse and team, they're like, nope, we're going to set you up on Monday. We got you an appointment with dietitian. Dawn, you're going to get trained on how to clean her port. Boom, boom, boom. So they became a significant part of the care team overall for those other things that, an oncologist is there to medically look in the book and do that. His or her job is to find a way to make the person better. The other whole aspect of it and the psychosocial side is everything else that you're going to face. So yeah, you ask for it from day one, or take a folder from the wall there, grab one of the folders, or just ask for a consult and it'll be done right away.
If you look up palliative, you'll find that that an important part of it is quality of life. And that's been mentioned a few times. And basically it's providing quality of life for people with some serious illness. Now, the question is, how do you define that quality of life? And that's a whole nother topic that, of course, becomes particularly personal, in the sense of what might be quality for me is not going to be quality for someone else. But nevertheless, that's a sort of a key phrase within the meaning of palliative.
Yeah, and that's why I think it's important to talk to your care team at the beginning and go, where are you at? What do you want? Like, some people want a lot of involvement. Other people, I respect everybody's opinion, and I'm not a patient. I'm not going through it. I would have my own journey and my own path now if I face it, only because of what I learned. I chose to get as educated as I could and involve as many people as I could, because it was training and helping me and helping us. So that's where I used it.
When are they opening the new facility?
Don't quote me. I believe it's May of next year, April or May. All I can tell you is, with no BS, it's on time and it's on budget.
Good.
So I think now that the campaign has started and there's a lot more media coming out about it, we're going to start hearing more and more. But it literally, when you drive by it, it looks finished, and it basically is finished. I think I think last month in our they always come and give us a quick presentation and show us some slides every month that I wish I could show you, but they never share them with us either, but shows us everything, which is awesome. And I think last month it was 92 or 97% completed. So, but remember, AHS doesn't own the building yet. This is interesting. They don't have the keys to the building yet. It's owned by another entity in PCL from a contractual standpoint. So it's going to take almost a full year to train everybody on the equipment, on all the, I'm not a doctor or nurse, policies, procedures, et cetera, et cetera. So the building needs to be done so they can have that transition time in the year to get everything ready. And then literally, once everything's been ticked off and once everything's been verified that it's good to go and everything, then AHS goes in and takes the keys. I hear they're over budget and a lot of equipment will be left at the baker. I am told at the highest level that it's on time and on budget. So,
Yeah.
And I'm not a politician.
If you have been following what happened when they opened the Cancer Center in Grand Prairie, what has to happen is once construction is complete, PCL they'll do this whole thing where they'll, ceremoniously turn over the keys to Alberta Health Services. But then there's another process called commissioning. And that's when all that equipment, all that expensive equipment will get moved from Tom Baker over to the new cancer center. It has to be set up and then the whole thing has to be cleaned. So there'll be a time, I believe commissioning starts November, could be wrong, but I believe November of 2022. It will take about 6 to 8 months before it's actually fully what they call commissioned. And then it'll be open to patient care.
Dawn, I will be joining the team on the 16th, I believe, of February.
Oh, great.
I got an email asking me to think about retail in the building. Like what? And that's really not my background other than, I could just guess about, Tim Hortons or restaurant that has meals, that sort of thing. And another thing that kind of sticks to my bonnet from the last 3 years has been, as a patient going for treatments, I've had to pay for parking all the time. And that will be something probably I personally would bring up, like that's an inconvenience to the patients. Yeah. I mean, I'm talking just the patients, not, visitors and so on. But I want to put this out to the board of directors too. And you. And yourself, yes. The boss here. What do you think, we should, what do you think that would look like, like for retail stuff over at the CCC?
Oh, I think it's great that you're going to be there and we're at that level to have that conversation. So these are the things, like going back, it's been all these different stages, right? Like there's bears and stuff. It's all Alberta focused on. There's bears and stuff that are in the concrete in the parking garage to make the parking garage look not so sterile and stuff. So we've been involved in all that kind of stuff. So these are kind of these next kind of steps, because wayfinding and stuff is starting now is exactly that. Like, okay, what should be where? Should it be a Timmy's or whatever? Should it be a sit down? Is it going to be cafeteria style, etc.? So I think those are good to have those group discussions, because it gets everybody thinking and gets the right people in the right room going down that path. Because I'm assuming they're probably going to have to go to an RFQ or something for all that kind of stuff, right? And then I love that you brought up parking. It's the number one thing in every meeting with every single person, including myself. So don't hesitate to bring it up again on the 16th.
Yeah, and also I was brought on board for my Aboriginal perspective.
Excellent. EDI and diversity and inclusion is huge, and a thing that Dorothy has been trying to get more and more, and we want more and more of. So that's awesome that we're going to have your involvement there.
Well, I've already had a few discussions with the management team on, what they think they can do, and what they can't do as well. Like, I mean, of course, there's fire restrictions and fire alarm restrictions and smoke detectors and so on. But I understand that there's an interior area that's outside, and they're looking at that as a multi-diversity type culture usage area.
Right.
So they're saying, well, we may have to use this one week as an East Indian area, and the next weekend, you know, as a Hungarian area, and you know, look after diversity.
Mm-hmm.
But anyways, I'm trying to get my thoughts around that. I'm already sensing the challenges, and I would like to get feedback from the group.
Yep.
Their thoughts.
You saw, if you think back to the video, if you saw at the very beginning, kind of where I was standing looking is that open. That's a very special area. So, and it's super important. And, you know, all these things like we're just talking about with inclusion and stuff, these are things in the discussions that we need to have. Have we captured everybody, all Albertans, all cultures, everybody's values? And are we showing true, you know, inclusivity and everything else? So I think that'll be a great discussion, and certainly one that needs to happen. And I'm glad it's happening now.
Yeah, this new facility in Calgary, does that have the ability to generate radioactive isotopes for treatments such as lutetium-117 and other isotopes?
I'm not the person to ask that one for sure. I am going to say I believe all of that has been covered now, and that was a big kind of wish from the planning committee when they initially did it, which is why the 2 LINACs are going to be the radiation vaults and stuff. That's been a major point of the whole facility overall. So I'm going to say I can find out for you properly and get you an answer.
That would be really good, because several of my friends in Edmonton are at a point where they're going to be needing that treatment. And the only place we can go is British Columbia, Mayo Clinic in the States, or several clinics down in Ontario way. And it would be a disappointment to see that Calgary and Alberta is again playing second fiddle to British Columbia.
Yep. I'm going to go on a thumb and say yes. But David, if you get me a note with the question, I'll get it answered tomorrow and get it back to your group.
Absolutely. I'll need your email address, but I can probably get that from Dorothy.
It's on the front page of my presentation.
Oh, very good. Okay, thank you.
Because I always like when there's questions afterwards. If somebody has a question, send me an email or phone me.
Sure. Don, I want to thank you. Your presentation has been absolutely delightful and most insightful. And I want to thank you. I wish you were on our board, but having looked at that page with all your activities, I knew that would not be a welcome thing to suggest for someone as busy as you. But anyway, I do want to thank you for your presentation tonight and taking time to talk to us as well as answer our questions.
Yeah, no, best wishes to everybody, and thank you so much. And I love that it's been two-way, like I said at the beginning, because that's the important stuff. I don't know a lot, but I've had some experience, so it's nice to share, and I get as much out of it as I hope you do. So don't hesitate to reach out, David, anytime. And you know, Dorothy knows how to get a hold of me and knows how to get me around the neck. So don't ever hesitate to call out.